Hello, everyone, and welcome back to another episode of the Core Consult RX podcast. My name is mcorvino, and my buddy is here as always, Cole Swanson. Cole, what's going on, man?
Doing great. Dude, it's just us.
I know.
It's just me, you, and Einstein over here.
Einstein, thinking. Just always thinking over here.
It's been a while because now, and people aren't in here, we can just talk about whatever we want. We don't have to be all
We
polite
can make
and
stuff up.
Yeah. People aren't going to call us out on our nonsense.
Well, they'll do it in the comments.
Yeah, but not while we're recording, so
That's true.
it's a little bit better.
We'll have a couple days of feeling good about ourselves.
Before we see it in the comments and the emails.
Yes.
You guys are idiots. It's never actually happened, by the way.
No. I've gotten a couple, random things, but not anything
They're
crazy.
polite usually, though.
Usually.
Yeah.
Not too bad.
I don't
Could be a
mind it.
lot worse.
Yeah, it could be.
Yeah, no, I don't get my feelings hurt too easily.
Yeah. So now we got another classic guideline episode with just the two of us.
Yep. Classic guidelines. For those of you who did not know, the Afib guidelines have been updated.
They have 2019, hot off the presses.
19.
If there's a guideline that comes out, you can count on us to do a very timely podcast.
Super timely. We should have done this the second it came out, though, just to really be like, what's
Yeah.
up?
We could. Well, and for all they know, we recorded it then, and we're just
We
releasing
did.
it now.
Wait, actually, I take that back.
Yeah.
We did do that.
Right now, it just came out. Dude, it just came out like an hour ago.
An hour ago.
Yeah.
We were part of the release party.
Yeah, we were on the research project.
So, yeah, it's not a big deal.
No. Something to add to the resume.
Yeah, it's one of those things.
Mm-hmm.
But yeah, so the AFib guidelines. We did an episode with AFib way back when we first got started.
It's episode 5.
Was it 5? Was
Yeah.
it 5?
It's Quattro.
Jeez.
Mm-hmm. It was with Paige the PA.
That's right. Old Steve, Page the PA. He was a student back then. Now he's a full-on PA.
He is? Is he
Yeah,
really?
he's doing
Okay.
critical care.
No way.
Yeah, he's living the big life now.
Good for him.
But yeah, so we did some... it was the AFib and stroke? Or I thought we did
Yeah,
stroke and then maybe touched on AFib?
Yeah, we touched on another cardiovascular or some type of cardiovascular condition.
Something like that.
Yeah, whatever.
But yeah, so we're not going to go through every single bit of it, and we'll go into the race 1, race 2 trials and affirm trials and all that, because I think we've done that before.
I think we hit those pretty good in
Yeah.
episode 5. So we'll do a nice little refresher on some of the anticoagulants, and we'll mainly hit the highlights of these new guidelines, and talk briefly about why they might have made these recommendations.
Yeah, absolutely. At least why we think they did.
Right, our postulations as to why they might have.
Our theories on the
Well,
matter.
I mean, we were on the research team, so we
It's true.
were in the room.
Yeah, no, basically our theories are just going to be reading their explanations.
Right. And yeah, these are the American Heart Association, American College of Cardiology, and Heart Rhythm Society. So it's basically a triple whammy of organizations that put this thing together.
They didn't even need my help on this one.
No.
Not even a
They
little
usually
bit.
call us, but
Almost always.
I think these were updating the 2014 guidelines.
Yep.
That sound right? Yeah.
2014.
Been 5 years.
It's been a minute.
Mm-hmm.
We got blood pressure guidelines, dyslipidemia guidelines, AFib. We got all the new guidelines.
Just
HRS.
rolling in them. Yeah.
So much cardiology. Where are you at, pulmonology?
Yeah, I know. What are you guys doing? You guys have triple inhalers, and there's no new guidelines.
Ugh. I wonder why.
No.
Well, that's a tale for another day.
I guess maybe it's a good thing because, they did their thing. They got their gold guidelines and, it's all good. Nothing else to update.
Gold guidelines get updated pretty frequently, though.
Yeah, I guess they
Not
do.
like a ton of new stuff usually, but enough. It's like the ADA. It's like the ADA
Put out like a
recommendations.
yearly type thing.
Yeah, every single stinking year.
Yep.
New guidelines.
Something new.
It's crazy. Keep those guys busy.
Yeah. And while we're not always guidelines are the end all be all, they
Yes.
are good little guidelines.
Yeah, good little guideline. So I'm actually, and I had this conversation with my student, actually, that's on rotation with me this month, because we were kind of talking through some of the stuff with HFrEF, and she kept quoting all the guidelines, and when I would say why, she's like, well, the guidelines say that. And, so we had this conversation that I try to have with a lot of my students, because somebody had it with me when I thought I was being clever by saying, well, that's what the guidelines say. And they were like, and then what? Who cares what the guideline? It's a guideline. How's that going to apply for every single patient? And so that's where we can, when we get more into the actual primary literature that the guidelines are based on, you can really get into like the nitty gritty of like the exclusion criteria and get a better understanding of the full patient population and hopefully make a little bit better patient specific decisions.
Yeah, guidelines are good to steer you in the right direction. And the way I think about it is, guidelines aren't always going to tell you exactly what to do for this patient, but they very well may tell you exactly what not to do for this patient. So you can be wrong by just totally ignoring guidelines and primary literature, but you could be more right by taking the guidelines to the next level and not always necessarily doing exactly what they say, but using it as a starting point.
And honestly, the other good thing too is taking them and going through the references
Yeah.
and actually seeing who they quote, because then you can just
Yeah,
have
because I mean they base it on
whole-
good stuff, you know, and then you can just
well, sometimes.
right, but for the most part, but your patients aren't always going to fit right into their boxes, and they know that, so
Yeah.
you do what you can.
So where should we start with these bad boys?
Yeah, so they've added some things. So we generally poo-poo edoxaban, which we still may, but they did throw that in there. It was added to the list of non-vitamin K oral anticoagulants, along with Eliquis, which is apixaban, and dabigatran and rivaroxaban. So it's in there. It's kind of the new kid on the block as far as the NOACs go, which, you know, I think we had this discussion, but I guess they're calling DOACs now. But in this guideline, they say NOACs. So
They do. I was surprised.
So I guess they have the say, right?
Who's to say?
I think it's because they mean, it doesn't mean like new oral. It means like novel oral or something.
Yeah, but they're not even that. They're not even.
Well, I guess they're novel because they're like first in their kind.
But there's like 100 of them now.
Yeah, you're right. So why
They're
are
not
they
thinking
novel?
it through.
No.
I think that somebody just likes to call them the new ones
I
because
think-
it's new guidelines. They're
they
just trying to keep
they
it.
just like acronyms and they can't get past it.
Yeah,
You know.
but it's cool because now we have a acronym for two different ones for the same stinking class.
There you go.
Yeah, why not?
So edoxaban. Why do we not like edoxaban so much?
So, besides the outcome data not being quite as impressive as like apixaban, for instance, what was it, the Einstein Timmy trial with AFib and whatnot. So, still, I mean, not a bad option, but it's expensive. It's probably more expensive, less covered, I should say. Also,
or probably less covered.
More insurance companies are going to be going with apixaban and rivaroxaban or Xarelto. But one of the weird things about edoxaban, Saveza is the brand name.
Is that the brand name?
Saveza? Yeah.
I don't think I've ever heard that brand name.
Really? I've
Yeah.
dispensed it one time.
Really?
And I was like a new pharmacist. Somebody had a prescription for it randomly.
Never dispensed it.
So if you have non-valvular AFib and you need anticoagulation, you can be on edoxaban unless your kidneys are just too healthy.
Yeah, if you're in too good a shape.
If your creatinine clearance is above 95 mils per minute, you can't use this drug.
Yeah.
I don't know of I'm sure there's other ones out there, but I don't know of a single drug off the top of my head that if your kidney function is too phenomenal.
Yeah, like we're not talking about kidney failure here. We're talking about kidney success.
Kidney success.
Full kidney success.
Yeah, that's what they call it.
Yeah. It's clinical terminology.
Your kidneys are always succeeding to continue to do the things that they're supposed
They're
to be
living
doing.
up to their full potential. They went to college and everything.
Yes.
You don't have to go to college to live up to your full potential. It's okay.
I'm just kidding. You don't. So basically, one of the first things that they mention is that patients with AFib and an elevated CHADS-VASc score. So remember, CHADS-VASc is kind of the tool we can use to assess someone's need for anticoagulation if they have atrial fibrillation. If you get a score of 2 or greater in men or 3 or greater in women, then oral anticoagulants are recommended. And like Cole said, they added edoxaban to that list now. So that's more complete list, I guess, than before, but probably don't suspect too many people are using it.
Can't see it popping up unless there's just no other option for those new ones, or if for some reason the insurance randomly prefers it. Otherwise, we like Eliquis for the most part.
Yeah.
And speaking of those CHADS-VASc scores, so they kind of threw this in there, which, the big one is that they're now recommending NOACs over warfarin, generally speaking. So in the past, it was kind of like either or, but now as long as they do have non-valvular AFib, they're saying, we would like to go with one of those NOACs if possible.
Mm-hmm. So that's definitely, because before they were just saying anticoagulation, so the fact that they actually pick one and recommend one over warfarin, it's pretty big.
Now, they didn't break it down, like they didn't say like Eliquis over Xarelto or
Right.
over dabigatran or anything, but they did say that class over warfarin if possible. And, we know the reasons. While warfarin's cheaper, for the most part, there's less monitoring. You still do have to do some follow-up and monitoring with these as far as it's mainly creatinine clearance and bleeding risk. But you don't have to do monthly INR checks, and you don't have to worry about what you eat. There's not so much of a bridging issue like warfarin and that sort of thing. Still situations where you would want to use warfarin, which we kind of went into detail on in our episode 5 podcast. But it's pretty nice. So I think while we were already seeing these a lot, we're going to see them more. And with that, hopefully prices come down. And in like 10 years, we'll be able to get generics. So yay.
Yep. That's going to be cool once they actually get generics. And we can be like, I remember when
it will be. Did you see that ProAir and Ventolin finally went generic?
Mm-hmm.
Yeah. A lot of the Medicaid insurances aren't covering it, though. So it makes for kind of a sticky situation. It's like, well, we don't have to brand it in anymore because we have all this generic.
And no one can pay for it.
Yeah, I know.
Not Cola. Sorry, that's you.
That is me.
Rich from RX Radio did a funny meme on his thing where he had some guy. It was like a picture of a guy acting like he's like following some female that he finds attractive, and his buddy's grabbing him. It's like his buddy has got like the word PA and non-formulary and all those things written on, and the girl's got Advair written on her, or Advair generic on. Right. And I was like, God knows. Yeah. He had it like within seconds of it being approved.
Yeah, Advair, Ventolin, and ProAir. Those are all generic now. It's pretty cool.
Yep.
Finally.
There you go.
I mean, those things were brand forever, way past the 17-year mark.
Way past.
Anyways, hopefully NOACs aren't like that.
Yes. So, what else? Where do we want to
go? We mentioned they're recommended over warfarin if it's non-valvular, so that means except in patients with moderate to severe mitral valve stenosis or prosthetic heart valves, basically because they just haven't been studied in that, right?
Well, there's actually been some studies, especially with like dabigatran, that's actually showed harm when you use in prosthetic valves.
With dabigatran being a little bit different, do you think they'll look into the others in that or no?
They may have already. To be totally honest with you, I can't
have.
tell you off the top of my head, but
Gotcha.
I feel like that they're kind of extrapolating the results if they haven't.
Right.
But who knows what's going to happen in the future.
One interesting recommendation, which they give a level of evidence B, because they rate all these, is the decision to use anticoagulants, which Mike mentioned to me earlier. They're using the terminology anticoagulants almost exclusively as opposed to like antithrombolytic or antithrombotic, because they're not really recommending aspirin anymore. They used to say, if you have a Chad's VASC of 1, then potentially you could just use aspirin and not anticoagulate. Yeah. But it doesn't really seem like they're saying that much
or
anymore.
Clopidogrel or any of those.
Right.
They're not using that. They're using strictly anticoagulation.
You can really find reasons to have a Chad VASC of 2 almost in any patient, for the most part. But they're saying that the decision shouldn't be influenced by whether it's paroxysmal or persistent AFib. So I feel like the old guidelines kind of mentioned that with paroxysmal, there's a chance that you wouldn't have to have long-term anticoagulation, potentially, depending on if if he has high bleed risk, blah blah blah, and you felt like it was okay. But now they're saying it doesn't matter, paroxysmal, persistent. They either need to be anticoagulated or they don't.
Yep. One of the other things I thought was interesting was the renal function. So they want they've always said renal function to assess it, but now they're also saying hepatic function as well. Mm-hmm. They added that to the kind of the baseline criteria to evaluate. The DOACs do have a hepatic dosing adjustments if necessary if someone has liver disease. So you got to kind of keep that in mind. Renal function is probably more so we would run into in these patients, but they did add hepatic into the baseline standard.
Yes. So while we say, hey, no monitoring with these NOACs, they are going to have to come and get blood work. Probably, I'm trying to think of how it was in the anticoagulation clinic I worked in. I think it was like they probably checked your creatinine clearance a month after starting, and then 3 months, then 6 months, then like a year, as long as everything was fine. You could go to annually. So there is a little bit of monitoring, and I think that occasionally they would get like a factor 10A, but I don't really think that's necessary. Mm-hmm. For the most part, it's just renal, and now they've thrown in hepatic. And the reason for that is, one, edoxaban, we mentioned if it's over 95, then you wouldn't want to use that. Eliquis's criteria, they have, you have to be 2 of 3, or if you have 2 of these 3 criteria, then you have to decrease the dose. Being over 80 years old, having a weight less than 60 kilograms, or serum creatinine greater than 1.5. So renal function comes into play there as well. So that's really the main thing to monitor. But otherwise, you don't have to monitor IRNR. And, they have a reversal agent now. So that used to be another big hang-up about it.
Yeah, and there's a lot of controversy surrounding that as well.
Yeah.
So we'll have to get Brian Gilbert on here to
Yeah.
go on that. He allowed me to jump on and help edit and some stuff, a paper that he's writing as a review about the reversal agent. We're in the process of trying to get it published right now.
So what does he think about it generally?
I think he's concerned.
Really?
Yeah. So there's just a lot of other things kind of going. A lot of things that you take it at face value. It's like, great, reversal agent,
Right.
done. But I've heard both sides. I've heard some of the negative, implications of it and some of the possible adverse effects and things like that versus just giving, blood. But I definitely think it just depends on who you ask.
Right.
I don't deal enough, and obviously in critical care to really give a great opinion.
Maybe we get Paige the PA on here too and see
That's a
what
good idea.
they got going on.
Mm-hmm. Let's not tell him what's about. It's just to see if he knows.
Sneak attack.
Yep. The other thing I do like, and this is still from the old guidelines as well, but they do say to reevaluate the need and the choice of anticoagulant therapy periodically for patients. So you want to reassess the stroke risk, reassess bleeding risk as well. The phrasing there though, the antithrombotic again was changed to anticoagulant in that case as well. But reassess. So putting someone on one of these anticoagulants and then just keeping them on for life, maybe not the best choice.
Right.
So reevaluating.
And along with the creatinine clearance, they mentioned that monitoring is important for that because if it's less than 15 and they're still indicated for anticoagulation, that is one situation where you'd want to, or it'd be reasonable to switch to warfarin from one of those. Mm-hmm. Yep.
And then they also added in that having a CHA2DS2-VASc score of 0 makes sense for men, and then 1 for women is reasonable to omit anticoagulant therapy.
And the reason that it's 1 for women is because women can't have a CHA2DS2-VASc of 0.
Right, because they're women.
Being a
That's
woman
point.
gives you a CHA2DS2-VASc of 1.
That's some sexist stuff, CHA2DS2-VASc.
I know. What are you guys doing? It's the 21st century.
That is not the move. You're gonna end up on CNN for sure.
Right.
No, it's they have that in there because statistically speaking, female gender does seem to be correlated with higher risk.
It's a risk factor.
However, they only really count that risk factor when it's combined with other members
So
or
if it
other
was-
ratings on the CHA2DS2-VASc. So if
it
you get a
was-
1, it's basically like getting a 0 for a guy.
Yeah.
They don't just hold that against you.
So why even throw it in? That's the
It
question.
is interesting.
Yeah.
It should be like a CHA2DS2-VASc plus maybe 1 if you're female.
Right. It should be like CHA2DS2-VASc 0 asterisk. You know,
The asterisk.
throw that in there.
That's a good move.
Mm-hmm.
That's how you do it.
They should have had me on that team.
My gosh. They feel so stupid right
I
now.
know. What do they think? Because they listen.
100%. So, we're, what else? Chronic kidney disease. So
Yes.
if a patient has a creatinine clearance of less than 15, or if they're on dialysis, the authors basically say it may be reasonable to prescribe warfarin with an INR range of 2 to 3 or apixaban.
Okay.
They actually list apixaban specifically.
So that's all right in kidney failure.
And then they have the other thing I like about these guidelines, especially with the summary articles, is they give this whole list of recommendations, and then they just give this like massive multi-paragraph box of all the different data. So you get to
have fun with
devour it in a couple of bite-sized pieces.
Eat it all up. So yeah, reversal agents. So dabigatran, they give these level of evidence in R, which I can only means like not rated because that's what TV means. But one is idarucimab or idarucizumab, which I heard one of my professors call like I dare you to use UMAB because it just was, I guess, dangerous back in the day when I was in school. But they
way
say,
back then.
yeah, way back then. But they say it can be useful. It's recombinant, they say it can be useful for reversing dabigatran, specifically in the event of a life-threatening bleed or an urgent procedure. So standardly you wouldn't, but that is a call that you can make, and it would probably be on your hospital's treatment algorithm in some way, I would suppose, if you guys even have it in your hospital.
I think some of them do. It's just so expensive still.
Yeah.
That's some of the feedback I've gotten from some of my inpatient friends. They say they have, it's available for them to get, but it's very expensive.
I don't really think about the inner workings of hospitals because I'm not there frequently, especially in an emergency situation. But my brother was telling me that they had one night where there was just two residents and they had a lady have a stroke. And, they were thinking about using the thing that breaks the clot, which I'm blanking on right now.
PCI?
Yeah.
You're talking about TPA. If it's a stroke, yeah.
Yeah, stroke, TPA. And they couldn't, even if she met criteria, like they couldn't administer it. They have to have a neurologist there. So I figured this would
probably a smart move.
Right. So I figured they would have to have some specialist here in that type of situation to sign off on and administer. But yes, there's a lot that kind of goes into these sorts of things.
So one of the other recommendations, and I actually think this one was in 2014 as well, but they have a situation where if a person's been on warfarin and they have to have some sort of a temporary interruption to that warfarin, whether it's like a procedure or whatever it may be, there's a question of whether or not we should then bridge with unfractionated heparin or low molecular weight heparin, as they're kind of getting back on it again. And that's for patients with AFib and mechanical heart valve. They're, like I said, need a procedure or an interruption of some kind for their warfarin. So bridging, we think of that more with like VTE when we talk about warfarin. And,
right.
and the reason for that, if you're not familiar, I think we've talked about this before, but if you're not familiar with it, it's, warfarin doesn't just, we always just say it blocks vitamin K, but what it's really doing is it's blocking the reduction of vitamin K. So it blocks the enzyme vitamin K epoxide reductase. And so as vitamin K comes into the diet, because we really can't store too much vitamin K, it's allowed to kind of shuttle off the oxidation reaction, and it has an epoxide metabolite that comes off of it, and that allows the clotting factor to become activated and kind of move down the clotting cascade, so our blood thickens. But we also have our anti-clotting factors, our natural anticoagulation, that are also vitamin K dependent. And so as warfarin starts blocking these, the activated factors or, anticoagulation that's been activated is already in the system. So you're basically having to just kind of let that to fizzle off, to be excreted, to be just out of the system. So you're basically on the half-life, and they all have different half-lives. So our anticoagulation, our natural anticoagulation, actually has significantly lower half-lives than our clotting cascade. And so the person ends up not being able to, they don't have protein C, protein S, antithrombin 3, things like that, so that they're blocking the clotting cascade and kind of keeping hemostasis in check. And so the person's actually in a hypercoagulable state with just warfarin. And so when we stop or start, for an interruption like that, in this case, because they've already been on it and then we're stopping it, they're saying maybe we should go ahead and bridge so that their person is not having a lapse and potentially increased stroke risk.
Right.
I know I said that fast, so I hope that made any kind of sense.
No, it's
I'm better at drawing that one out.
It's reiterating, because we've said it before, so it's good.
Yeah, there you go.
So hopefully because we tend to repeat ourselves with lots of things, especially when it comes to primary care
Because
stuff.
we also don't know a lot, so.
Well, it helps you remember. That's what
it is.
It's what
You got to pull from what you got in the toolbox.
Our podcast is limited to our knowledge.
Ooh.
Uh-oh.
Cannot believe we made it to episode 50.
I know. We're going to make it to 1,000. Who knows?
Probably not.
Yeah, we'll see.
We are long off the air by then. Keep telling me YouTube and wherever else.
So yeah, the new factor 10A recombinant factor reversal agent. So it's andexanet alpha. They say it can be useful for reversal of rivaroxaban and apixaban in the event of a life-threatening bleed. We've already mentioned that has some scrutiny and is up for debate. But if it's if you think it's warranted, it is an option.
There you go. And it was on an accelerated approval pathway too, so they rushed it through.
Did they really?
Mm-hmm. So when we think of blood kind of pumping through the heart, we think of our left atrial appendage, where blood is allowed to flow and is in excess of as the blood's kind of just going through the heart. However, someone with AFib, because the heart is potentially beating irregularly, the blood in that left atrial appendage can pool, and that gives it a chance to form a clot, and then your heart can then kick that clot out, and you could potentially have a stroke. So one of the updated aspects of the guidelines was based on the approval of something called the Watchman device. Mm-hmm. Have you seen this at all?
I have, actually. I had a patient in one of my rotational clinics that had that procedure done.
It's really cool.
Yeah.
I'll put the link to the YouTube video that the company made. But yeah, they basically will take this. It looks like a PCI, kind of like a balloon, like if you're going to do a stent. But you send it through. It looks like a bottle cap or a cap on top of a wine bottle or champagne bottle rather. It's really weird looking, but it goes up through like the femoral artery, goes through, and then it basically just covers the hole leading to the left arterial appendage, blocks it, and becomes part of the tissue, and blood can no longer flow there. And so they're saying that if a patient has AFib and is at an increased risk of stroke, and they have some sort of a contraindication to long-term anticoagulation, that this is definitely something to consider.
Yeah, I remember because he was on anticoagulation and he came off after it was done. We actually saw another guy with it, I think, but he was having some complications. I don't think it's benign completely, but yeah, very interesting. Very cool procedure.
Yeah, it is. There's if you're interested in looking more at that, there's the Protect AF trial and then the Prevail trial. They kind of looked at the outcome data with that device.
Awesome. Something else very interesting that they've thrown in, which I'm not sure if this was referenced at all in the old guideline, but in patients with AFib who are at risk who have undergone stenting, coronary artery stenting, they talk about double therapy versus triple therapy. So this kind of threw me for a loop on one of my rotations because, in stenting, frequently you're going to do dual antiplatelet therapy. But then a lot of times these patients also have AFib. So are we using all three agents? Seems like a lot of anticoagulation and anti-platelet options. So what this guideline recommends is that double therapy with Plavix and low-dose rivaroxaban, which they consider 15 milligrams a day, or dabigatran, 150 twice a day, is reasonable to reduce the risk of bleeding compared to triple therapy. So I don't think they give this a really high level of evidence recommendation. But if you really look into the trials on this, there's only a few, but they're pretty interesting and some are very strange. But actually, Dr. Bragg talked about this a lot, and I think he's an advocate of the double therapy as well, as opposed to triple, because it potentially increases your risk, and you're probably covered just with the two as best as you need to be. But we can go more in depth on trials on that someday, because there's some
a lot
interesting stuff. Yeah.
Another thing too, I'll mention, this isn't really our area of expertise, but I will mention it because it's in the guidelines, where they have new evidence from the Castle AF trial, which looked at catheter ablation, and specifically in patients that have symptomatic atrial fibrillation and reduced ejection fraction heart failure. And when they did the catheter ablation, they actually had a potential to lower mortality rate and reduce hospitalization for the heart failure. So that's been added and increased in level of evidence because of the new trials that have come out.
Awesome. And they also recommend weight loss in combination with other risk factor modification, specifically for overweight and obese patients. And they, as well as patients with cryptogenic stroke, where external ambulatory monitoring is not conclusive, you can implant a cardiac monitor device, potentially to detect subclinical AFib. And I guess that's more of a kind of in-depth diagnostic situation. Yeah, those are the major updates.
Yeah, anything else that we missed? I'm sure there's something.
I think there's a lot there, but these are kind of the big either changes or things to know. It's kind of like the executive summary.
I like that, the executive summary.
Yeah.
This is the most important summary that could possibly have put together.
Whenever Dr. Wirt says, "Did you read that guideline?" we say, "Well, we saw the executive summary."
That we made up.
Did you read it?
Well, no.
Yeah.
So we'll put a link to the guidelines, either Instagram or Medium. We're gonna get back with the show notes. We start them and then we stop them when we get slack. So forgive us. We're trying to keep everything together. We just like we always say, we need more interns.
We just need some interns is all.
I have so many students, I think, starting next year.
Oh,
like in a couple months when the new group comes through. So we'll be getting a lot more done then.
And there's going to be some day where we're like, stop sending us interns. We have way too many interns.
So I'm actually worried, though, because I'm a preceptor now at 3 different schools.
Uh-huh.
And I know for a fact there's 1 month where I have 2 guys from Miami coming to be on rotation with me. And I'm like, with my luck, I'm going to have, 2 from Miami, 2 from MUSC, 2 from Presbyterian. And I'm going to have like 6 people just following me around like an army of students.
I mean, can you black out the month to the other ones and say, I'm kind of booked up? Or are you just like, if I have 6, I have 6?
I have 6. Why not?
I mean, do you have enough work for them to do?
You only YOLO once.
You only live once.
No, because I mean, like, what I'll do is I'll have them shadowing clinicians. I'll have them going and seeing paid. Like, we'll make it work.
Yeah.
Now, this particular setting, like that I'm in now. Now, if I was still like, working in the community setting, it'd be it'd be a lot more difficult. Yeah,
6 people in there.
Yeah, just like standing around. But yeah, it's such a big spot. I can have them going to different sites, and yeah, you can do a lot more.
Yeah, it's pretty cool.
I'm kind of learning as I go with this because I've never done this is my first. Nick and Patrick were technically my first 2 students, but
on this job site.
Yeah, but I just started myself, so I really didn't know. So this is the first month where I'm like,
did theirs go okay? How was theirs?
Yeah, I mean that's them.
Right,
they seemed happy.
It was awesome.
Yeah, they had
ever.
the best month of their lives. Changed their lives forever
by far.
Yeah, Patrick actually texted me today saying he got an interview with the top schools that he interviewed for residency or put in for residency.
Excellent.
It's gonna be the man.
It's good to hear.
Yeah,
USC does that. They get those guys out to residency.
There you go.
For sure.
Yeah, so we'll see. I'm excited to kind of see this next group of students. I'm hoping we can really elevate the podcast and everything else we got going on.
See who wants to get involved, and we will allow that. That's for sure.
We got the owner of TLDR Pharmacy.
Oh yeah,
he wants to come on the podcast.
Sweet.
I talked to him over email.
His stuff.
If you guys haven't seen his articles, they are some of the best. And as competitive as I am, this almost pains me to say, but they're so stinking good.
Yeah, they're great.
His warfarin article, it broke down like the dosing and all that. I'll put a link to it. It was phenomenal.
Yeah,
I read it and I was like, "Jeez, these are so well written." So he does a fantastic job. So make sure you check out his stuff. He's got a Facebook page and several other things, but his articles are really his thing. But he'll come on here, talk. He's an oncology specialist himself. So
really?
Hopefully we can get some oncology going.
Before him, I didn't even know what that acronym or that abbreviation meant.
Dude, I know I'm gonna love this guy just because he decided to name his blog company is too long. Don't read. I'm like, that's hilarious. You're telling someone not to read the blog. That is the whole purpose of that is hilarious.
Yeah.
So that's perfect. So I'm looking forward to having him. Other people, we got coming up. But if you guys are all, anybody's listening, you're like, hey, wait a minute.
I've got something to add.
I have something to add.
I'm smart and I work in healthcare.
Yeah, shoot us an email.
Doesn't have to be pharmacist. Doesn't have to be PA. Doesn't have to be doctor. We take everyone.
We actually really want some nurses on here.
Yeah.
We're in the market to find a couple nurses to come on.
We've had some, but we can have more.
Yes, for sure. We've only had 1 or 2.
Two at least.
We've had an overabundance of pharmacists just because we happen to be pharmacists.
We tend to know
we're
them.
biased, which we don't want to be. So yeah, anybody else? If you're a pharmacist, don't even ask because you're already booked.
Yeah, we got enough of you.
We got enough of you guys, but anybody else? Like we definitely want to hear from everybody. Different specialties. Keep it rolling. So
it was nice to be on our own today, though.
Yeah,
that's good. As much as we love guests.
Yeah. Keep it going.
Cool.
All right, guys. Thank you so much for listening. As always, we greatly appreciate the fact that even 2 people are listening. So when we see how many downloads it's getting a month, it's really exciting. Please let us know what we can do to improve. If you have any suggestions, feedback, anything like that, please email us. Reach out to us on any of the big social media platforms. And we will hopefully hear from you guys soon. See you next time. Y'all take it easy.